Good morning and welcome to the 2025 Speaker Series celebrating Autoimmune Encephalitis Awareness Month. My name is Tabitha Orth. I'm Executive Director and founder of the International Autoimmune Encephalitis Society. For those of you watching, I also want you to know that the recording of this webinar will be uploaded onto our YouTube channel, and we advise that you go there and subscribe to the channel, click the notification bell so you receive all of the different webinars we will be hosting during Autoimmune Encephalitis Awareness Month. At the end of the presentation, as time allows, we'll have a question and answer period. And so if you go to the bottom of your screen, you'll see a box for questions and answers, and you can place them there. We ask that patients and family members, if you have a question, please make that a general question because the doctor cannot answer anything that's case specific. Today, we're very excited to open our speaker series with Dr. Yasir Jassam, who's from Hoag Medical Group in Newport, California. And he's going to be speaking about autoimmune epilepsy, diagnosis and treatment, which will be focused on seizures due to autoimmune encephalitis and autoimmune cause. He's internationally recognized neurologist and neuroimmunologist who focuses on autoimmune neurological and neuroinflammatory diseases, such as autoimmune encephalitis, multiple sclerosis, neuromyelitis optica, transverse myelitis, optical neuritis, CNS vasculitis, and others. He has established himself as a pioneer force in neurological care and the director of the Multiple Sclerosis and Neuroimmunology program within the Pickup Family Neuroscience Institute. His leadership extends to his role as chief of the Neurology Division of Hoag's Specialty Clinic and current chair of Hoag's Department of Neurology and Psychiatry, where he oversees comprehensive patient care and program development. Under his guidance, Hoag's Neuroimmunology program has expanded its capabilities in treating complex neurological conditions. His expertise in multiple sclerosis and other demyelinating diseases has been instrumental in developing cutting-edge treatment protocols and implementing advanced therapeutic approaches for patients with autoimmune neurological disorders. Since joining Hoag in March of 2021, he's been actively involved in clinical research, particularly focused on MS and other neuroimmunological disorders such as autoimmune encephalitis. His research initiatives at Hoag contribute to the advancement of treatment options and improved understanding of neuroimmunological conditions. His commitment to research alongside with clinical practice ensures that Hoag patients have access to the latest developments in neurological care. We're so pleased to have you here with us today as our first speaker in the series, Dr. Jassam. Welcome.
Thank you, Tabitha, and thank you for inviting me to participate. I and Tabitha were talking beforehand about some of the aspects, and I'm very pleased to know the international audience here. As she said, I'm Yasir Jassam. My specialty is neurology and neuroimmunology. I currently am the director of the neuroimmunology unit at Hoag, and I'm also the chief of neurology there. So I'm going to start with just saying that I don't have any disclosure regarding this topic, apart from the fact that I am a primary investigator on one of the autoimmune encephalitis clinical trials called CELIO, which is ongoing now in our institution. I've also participated in an advisor board. One important disclaimer is that I am not a pediatric neurologist because the world of autoimmune encephalitis in pediatrics is a little bit different there, and there are a lot of more zebras than we see in the adult population. So I might not be the best voice for that. So today I'm going to tell you about a little bit of a spin-off, if you wish, from the encephalitis story. This is autoimmune epilepsy, which I think and I firmly believe should be differentiated from encephalitis. Now, both can be confused together. And we will talk a little bit about what is autoimmune epilepsy and how is it different from other epilepsy types. We'll try to displace a little bit of the emphasis about how it resembles some of the patients who will come with autoimmune encephalitis and how we can diagnose and treat it, and the future of these entities. Now, first of all, what is a seizure? A seizure is basically too much electricity in the brain. And if you go to the literal definition, it's an excessive and hypersynchronous brain activity. So basically a group of neurons who decide to fire together at a high rate, causing an abnormal activity. And epilepsy is the term used when there's a brain that has a predisposition to have recurrent seizures. And the term epileptogenic that you might hear very much is basically the network of these nerves and neuron cells that can promote a seizure. Now, when do we call a seizure autoimmune? When the seizure is caused by an autoimmune disease or an autoimmune cause. Now, seizures have many, many causes, one of which is autoimmunity. And it's been described since the beginning of time. It's actually, there's animal experiments go back to the 60s and 70s of the 20th century that talks about that. One of the famous pediatric forms of encephalitis called Rasmussen encephalitis, which is very rare yet very devastating, is basically just led by seizures. The GAT65, which is again a very famous autoimmune antibody that has been linked to autoimmune epilepsy. Believe it or not, 5 to 7% of all epilepsy is autoimmune. So it's not a trivial cause of epilepsy. And to add to more, 15 to 20% of people who have no clear cause of epilepsy when tested end up having an autoimmune cause for their epilepsy. So the relationship between the autoimmune or the immunological system and seizures are actually closer than when we think. So some general rules that I'd like to share with you before diving into the kind of the bread and butter of this. Usually, if you have somebody presenting with an autoimmune epilepsy, especially sometimes in pediatric group, you might get some sort of a prodrome of an infection, some sort of a viral infection or a fever, and the patient starts seizing. Whether or not this is a causality or just it's making the brain more susceptible to have seizures is not very well known. But viral infections have been well linked to autoimmune epilepsy and also to autoimmune encephalitis. Now, symptoms usually will precede the incidence of the seizure by about a couple of weeks. There are two entities that are now being recognized in patients who have some sort of a viral infection or a very trivial infectious disease, and they end up in something called NORS or FIRES, which is basically a very difficult status epilepticus. They will have refractory seizures that are very difficult to treat, and they are thought nowadays to be one of the causes of autoimmune or one of the cases of autoimmune encephalitis because of the response we're seeing in some of these cases to immunotherapies. Now, some of the features that can suggest an additional role of the immune system are symptoms of psychosis, dyskinesias, something called dyskinesias. I'm trying to not kind of refrain away from just the jargons, but dyskinesia is basically abnormal movements of the body and the face. Dysautonomia, when the patient's vital signs becomes very erratic. Some abnormal contractions of the face and the arm. Changes in the metabolic profiles, such as sodium, which you can see a lot of limbic encephalitis. Now, this can be seen in cases of limbic encephalitis and also can be seen in epilepsy. I'm going to throw in one fact here, or it's kind of one agreement that is now becoming more transparent, and it has been a debate for some time. Unfortunately, the rate of misdiagnosis in both ways in autoimmune encephalitis and autoimmune epilepsy is very high, meaning that we used to have no good test to recognize these. So we assume that many of these cases were missed because back in the day, we did not look for them. And now we actually see a different swing of the pendulum, which we're seeing a lot of mislabeling of other causes of epilepsy or even psychosis as autoimmune for the lack of better understanding, or sometimes because of the placebo response to treatment. This is has been illustrated very well in a nice paper that was published out of the Mayo Clinic recently that illustrated many cases that were misdiagnosed as autoimmune encephalitis and the causes for which it was found eventually. So we have to be very judicial about using these antibodies and these tests and labeling people with autoimmune encephalitis, because it's really it's a life-changing diagnosis. And I understand that we do understand as physicians the hope the word autoimmune provides to patients and their families, because at least it tells you there's some light at the end of the tunnel. But sometimes these therapies can be very burdensome, very serious, with a lot of side effects, and also economically burdensome. So the correct diagnosis is vital. We spoke a little bit about NORS and fires, and I'm going to elaborate a little bit here. So NORS is the new onset refractory status epilepticus. And a status epilepticus is when the person continues to seize without a break for 30 minutes or more. And fires is when there's fever involved. So it's a febrile illness related to refractory seizures. So NORS doesn't have to have a fever with it. Fires, you'll see a fever with it. And usually those patients are called refractory when they fail 2 seizure medications added together at the same time. So we add 2 seizure medications and they continue to have seizures. And there's very, very limited evidence, as I said, suggests that we can stop NORS in a few cases with immunotherapies. Some cases have used IV steroids, IVIG in a couple of times, in about 5% in both of these conditions, plasma exchange. There have been some cryptogenic antibodies found in these disorders, and you can see the percentage there. There was a child reported with the case of fires that were found to have inflammatory cytokines in the CSF, and they were treated with a medication that blocks something called IL-1, and IL-1 is a very important cytokine and inflammatory mediator. Other cases have been used with IL-6 blockade, a medication called tocilizumab, just to tell us that the response in these cases suggests that there could be an autoimmune cause to this. However, I'll throw a little bit of a wrench in that concept at the very end, because now there is a very interesting concept. It's not recent, it has been now illustrated for a while, that seizures themselves, when they happen, they can ignite and indicate the immune system to be active. So the chicken and egg is a little bit of an argument there, what starts first. But it is at least acceptable that using immunotherapy in some of these cases have produced good therapeutic effects. Now, if we, this is a slide that is a little bit kind of complex in terms of the pathophysiology, but I will try to take the kind of the general scope of it. What it tells us is that there are truly, for the seizure to happen, we usually have something called a balance between excitation and inhibition in the brain. So when some of the nerves are trying to fire, some other nerves are trying to stay quiet. And when we lose that, we basically are losing the synchrony between the brain cells. And that's where those cells can go haywire and start to fire. And when this happens, you see that there is an immune response that starts because we're injuring neurons. And when you injure neurons in the brain, the immune system gets activated. And all these letters that you see in front of you are basically proteins that get activated when the nervous system is injured. And that will lead eventually to a brain barrier damage and some neuronal dysfunction, which can explain the long-term effect or the damage we see. And the seizure itself, when it happens, is actually, again, because of probably a similar etiology, can activate both innate immune cells like microglia and adaptive immune cytokines such as interleukins and interferons. And the history of this, going back in time, this concept is not recent. As I said, back in the 60s, they started to find antibodies that are linked to attacking the brain, some of which can present with seizures only, and some of which can present with a difference of cognitive and other deficits in addition to the seizures, with or without. And we used to see those antibodies coming every decade. Nowadays, we started to see them coming every year, if not every few months, because we have now mastered, or many labs and entities have mastered the techniques of the discovery of new antibodies. And it's interesting when we attend as neurologists and experts those meetings, we see the amount of new antibodies and new entities being described that we didn't have an answer to in the past. Now, again, to be on the devil's advocate side, some of these antibodies have been advocated to be not pathological, but they're because they're kind of bystanders. But still, they might serve as good biomarkers of the disease. Moral of the story: we're well informed about these kind of conditions now, and patients, luckily now, have better chances of having these tested and treated than when I probably started to train in neurology, when we had a little bit access to those resources and tests. Now, the relevance of the antibody, as I said, it basically has to be examined carefully. Seizures and epilepsy syndromes that can happen to immune-mediated mechanism usually happen due to an antibody, which is basically an immune protein secreted by a B cell, a B lymphocyte, that attacks the cell surface of the nervous system, and that can cause the damage. Now, there is another form of immune response called cell-mediated, and that's basically mediated by something called natural killer cells or T lymphocytes. And when this happens, or even in innate immune cells, like what we said, the microglia and the macrophages, but when this happens, we usually see that these immune responses are not due to just autoimmunity, and there is a concern about usually cancer happening that can cause that response. And in that case, if you find an antibody that comes from inside the cell, the likelihood for this antibody to be pathological as the cause of the disease is lower than antibodies that attack the surface. As I said, the patient might have an underlying autoimmune disease with his condition, or a malignancy, which is very important. So the International League Against Epilepsy in 2017 described the autoimmune epilepsy as seizures caused by the immune response against the brain, with seizures being the core symptoms. And this is what we're talking about. So when we differentiate autoimmune epilepsy from autoimmune encephalitis, the core feature in epilepsy is seizures. So the patient is otherwise well. They don't have the cognitive decline. They might have it because of the seizure, but they don't present with that encephalopathic feature unless they're seizing nonstop. And in many entities, they can mingle and they can coexist together. However, if you want to call somebody with autoimmune epilepsy, you have to have no evidence of other features of encephalitis, such as brain damage, weakness, numbness, vision loss, cognitive decline, severe psychosis, and so forth, unless related to the seizure itself. But it's still 30% to above to almost 100% in some reports of encephalitis patients will have seizures that can be lasting or sometimes not lasting, except a few entities. Now, how do we recognize this? Researchers and doctors have tried for some time to develop some sort of an algorithm to see if a seizure patient might have their seizures because of an autoimmune disease. So they developed a score called the APE2 score, which basically tries to go through some points in the history and the examination, and they try to culminate a score to see if how likelihood for this seizure to be due to the autoimmune response. And I'm not going to dive in details into this score, but just to tell you that this score has been modified a couple of times, and they also made a different score by adding a couple additional points, asking about immunotherapy and the detection of an antibody in the serum. And they made a different score called RITE, or RITE, which has this time 19 points. And that is also used to recognize this. So the proposed approach to label somebody with autoimmune epilepsy is that, and that's what I do in my practice, is that if I can ask that, could this patient have autoimmune epilepsy because they haven't been treated with many seizure meds and it's not working well. They do have some history of autoimmunity. So we usually calculate the APE score. And if the APE score is less than 4, then it's highly unlikely that this is autoimmune. Now, sometimes if that score, the AP2 score, is more than 4, then we go ahead and check for the neuronal antibodies. And there are many ways and labs to do that. And if positive, then that's what I call, or is proposed to be called, a definite case of autoimmune epilepsy. But if negative, then a trial of immunotherapy, if again effective, would be helpful, but that's only recommended if the original APE score was 7 or more. And that's, they call it, the AE is now probable. Now, if you try it and there is no response to immunotherapy, then it's not likely to be autoimmune epilepsy. The possibility always stays there because there are some cases that don't respond from the beginning to certain agents. Or if you see the APE2 scores between 4 to 6. So to make it simple, less than 4, highly unlikely. I usually don't test. Above 4, we go ahead and test for the antibody. If it's positive, we call this a definite. If it's between 4 and 6, we call it a possible, and we would consider sometimes immunotherapy. But it's above 7, we definitely try immunotherapy to look for a response. And then we always use different ancillary testing, just like you do in other cases of autoimmune encephalitis, because you can see some pathognomonic or at least suggestive characteristics of these conditions. Like on the MRI, you can see some abnormal signals in certain areas of the brain that can suggest a certain entity or a syndrome. We can see it sometimes in pediatrics, usually when patient presents in cases of autoimmune encephalitis with what we call cerebellar or brain atrophy. That is a little bit disproportionate, like Rasmussen, for example, encephalitis, and that can suggest certain thing, changes in the basal ganglia. We do certain specific MRI, something called DTI or SPECT, to look for a hypermetabolic or even a hypometabolic region that can give us a little bit of information that inflammation is happening there. EEG sometimes has a very specific pattern, like in NMDA encephalitis, for example. It can have something called the delta brush, which is characteristic, if not pathognomonic, because I don't know any or many other diseases that can have that. And this can give you a good clue. Now, this, we call it ancillary because there is no equivalent to the patient, seeing the patient at the bedside, hearing the story, usually from caregivers or sometimes from the patient themselves, and doing the examination, looking for the dyskinesia, looking for the autonomic function, and trying to assess overall the likelihood, in addition to the simple tests that we do at the bedside, like the CSF and the the fundus examination. Cancer screening, I consider it to be paramount, at least in the adult population. I know even in pediatrics, it can be associated with malignancy, but a truly adult onset cancer screening, especially in certain syndromes, and we go through them when we talk about the autoimmune encephalitis patterns and syndromes. But this is kind of a quick run to what cancer screen might be in my practice, but it's not exclusive or inclusive by any chance. So we'll start talking about some of these syndromes very quickly, because I'm sure that as a society or a community that is well acquainted with autoimmune encephalitis, you probably have heard these terms ad nauseum. But I usually try to look at them in the way that are pattern recognized, or there's usually a pattern to those. So I usually like to put NMDA and LGI1 head to head, because they're truly what they call mirror images to each other. One is more prominent in females and younger age. The other one is males, older age. There is characteristic cancer of teratoma with NMDA, where thymoma is the theme in some of the cases, while truly LGI1 is mostly autoimmune, and cancer is not supposed to be a big part of it. MRI can have non-specific changes in NMDA. However, in LGI1, it can have a typical medial temporal hyperintensity. They both respond well to immunotherapy with kind of well being in quotes. I have seen different first-line therapies are working in NMDA and LGI1. We consider corticosteroids to be the mainstay these days because other immunotherapies, at least the ones that we use as first and second line, have proven to be less effective. There are ongoing trials, as you might know, to be both these indications to find agents that might be better suited. Just to throw things there, in LGI1, there's another potassium channel antibody called Caspr2, which can add a peripheral picture to this called neuromyotonia. And Caspr2 is also a rare cause of encephalitis. But it's usually considered to be a peripheral disorder that can cause a very abnormal muscle tone. Then we talk about what we call the GABAs, and the GABAs are a group of antibodies that control the inhibition pathway of the brain. And here I put the risk of cancer, although their names are a little bit similar, the presentation is again different. Again, you see GABA B mostly over in men over 60, and you see the GABA A in the median age of about 40, and females and males are equal. They both can come with what we call crescendo seizures. I think it's more pronounced in GABA B, where basically the hallmark of the disease is these refractory, difficult to treat seizures and non-convulsive status that can be very difficult to treat. Be aware of those because, as we say, it comes with males above the age of 60, and there's a very high, but when I say about 50% association with a small cell lung cancer, and you do see some abnormal signals of the brain and in the medial temporal lobe, and a decent response, about 60% to immunotherapy. GABA A, the MRI is very characteristic, and I don't think I put a picture of the MRI there, but if you just Google GABA A MRI of the brain, you'll see the brain, it presents with those fluffy, big white spots that any radiologist, by looking at them, will tell you, I think this is GABA A, if it's a neuroradiologist trained. It's very characteristic of the disease, and in my mind, it's probably much easier to spot than GABA B. You have to be aware that those two antibodies are usually not available in all autoimmune encephalitis assays, and sometimes you have to request them. So even with the most extensive paraneoplastic assays, you might not find them. So it's highly advised that there's a good suspicion in refractory seizures or crescendo seizures with non-convulsive status that you consider testing for those if the pattern is suggested. And then we're still talking about the cell surface antibodies here, and we'll talk a little bit about less frequent antibodies. One is called AMPA and mGluR5 antibodies. Those are low frequency. mGluR5 is famous for something called the Ophelia syndrome, based on a description of a case. And that basically presents with a behavioral disorder, abnormal movements, and seizures, usually associated in cases of Hodgkin's lymphoma. Excellent response to therapy and no much history of recurrence. Now, this is very important because it's very important to know if the encephalitis has high risk of recurrence or not, because sometimes people and patients and even doctors ask you how long to treat the condition. There are some sorts of encephalitis, like say LGI1 or even DPPX, has very high rates of recurrence. So although they respond well to immunotherapy, once you wean off the immunotherapy, they will come back again. In these cases, the risk of recurrence is a little bit less. And even in AMPA, although it's a presentation of limbic encephalitis or encephalopathy, which is typical with the median temporal lobe MRI signal, it can have a refractory course and it can have a brain atrophy with it, which can make it a little bit difficult. That does not mean per se that this is a recurrence. It just means that the seizures have happened because the brain is damaged. So although the inflammation is gone, the damage will continue to cause the seizures. And this is another very important point in encephalitis, and it makes it very difficult to manage these patients. So let's imagine that there's an immune response against the brain, and that immune response leaves a scar or damage in the brain. Now, the damage might cause seizures or cognitive dysfunction or another dysfunction of the nervous system. And the patient is being treated with immunotherapy. However, the patient does not recover well. And the question is not why is the patient not recovering? And does that mean that the treatment has failed? Well, sometimes it is, but sometimes also it means that the brain has been damaged now and it's been scarred, and it can't take a long time to heal. And healing does not depend on the therapy, but it depends on the individual themselves. I usually make a simple example in my clinic, say that if I cut my skin and cut the person next to me, we heal at very different rates. And what defines how we heal is our general health, our genetics, our diet, and our environment, in addition to others. And so is the brain. The healing response in the brain is so much determined by the inert biology, the inner biology of the body, and not by the immunotherapy. So it is very important to understand. And unfortunately, in some of these cases, we don't have good biomarkers to say whether or not the immune response has stopped, because even those antibodies, once they're positive, they can remain positive for a long time. And that does not mean that you need to keep treating them. But I usually get guided by some of the CSF changes, there's still inflammation, the EEG, and if there is recurrence. However, if the question is just recurrent seizures, and I do see on the MRI, for example, that there's permanent brain damage there, I usually don't overdo it and don't push for more and more immunotherapy. We continue the theme of cell surface antibodies, and now we're getting into ones that are a little bit rare, like a glycine receptor antibody. This is the new entity that has been also described in stiff person syndrome. It can actually cause encephalitis in 13%, and also can cause a condition called PERM, which is basically progressive encephalopathy, rigidity, and myoclonus, which is the end spectrum of stiff person syndrome, one of the most difficult cases. In addition to GAD65, this can be caused by glycine. It can be seen in thymoma, decent response to immunotherapy, and low risk of recurrence. Neurorexin 3, usually in females around the age of 40. It can actually present in many different types and phenotypes, but usually there is a GI component. So you see a lot of confusion. The patient presents with abnormal movement, some dysautonomia with hyperventilation, but diarrhea is one of the most important ones. There is one more antibody that shares that GI function that I found to be a helpful hint, which is DPPX6. So these two can affect the GI symptoms. And somebody, when they tell you that they have been having some GI issues like chronic diarrhea, it's important to know. Neurorexin 3 has no clear cancer association and responds well. And the recurrence rate is not well established. So we truly don't know much about this because it's a very rare entity. So I was speaking about dipeptidase like protein 6 IgG, and that's what we go for, a short DPPX 6. It's usually affecting males in their middle age. It's a potassium channel antibody. It will present very similar to neurorexin with diarrhea, dyskinesias, but I have seen a lot of cerebellar ataxia and cerebellar involvement with it as well. Seizures is an important component, and it can have that firm presentation to it. It can be associated with lymphoma. So if you see a patient with that, they should be screened for lymphomas. Caspr2, we mentioned it briefly with the LGI1. It's the, I call it the akin of one of the potassium channel blockers. So it's one of these siblings for LGI1. It is a little bit less common, but it can be safely recognized or kind of seen when somebody sees those abnormal movements of the muscles. We term neuromyotonia. There's something called Morvan syndrome, which happens when the central nervous system and the peripheral nervous system are involved. So you see both encephalitis and the neuromyotonia, and not necessarily you'll see an LGI1, but Caspr2 by itself can do that. And again, association with thymoma. Thymoma, as you might have seen now, is a common theme in addition to cell cancer and hematological malignancies in many of these syndromes because they're very immunogenic. Caspr2, like LGI1, does have a decent risk of recurrence. So follow-up is needed and long-term immunotherapy might be needed as well. Now we're talking about, we're going to shift gears a little bit and talk about what we call intracellular antibodies. Remember, these are the antibodies that we said might not be pathogenic, but might be a bystander from the cell destroying the target cell in the nervous system. But GAT65 is a very interesting antibody that has been debated for decades. It has multiple phenotypes, from seizures to cognitive disorders to ataxias to stiff person syndrome. And it's still not known the exact pathogenic mechanisms, although it has been proposed that the antibody, although intracellular, does have a pathogenic component to it. There is a small chance of cancer with it, but it's usually considered to be an autoimmune disease. Ampifysin antibody, on the other side, is also a stiff person on the stiff person syndrome spectrum, but can cause limbic encephalitis. This one doesn't present with some, although non-specific, but if you see a pattern of those cortical and subcortical features, it can suggest that in a person who has a presentation consistent with a stiff person, it can suggest that this is ampifysin, not GAT65. Ampifysin antibody is correlated highly with cancer of the lung and also breast cancer in women. Those are kind of the old terminology for and their new names for the paraneoplastic antibody. If you are in the business of neuroimmunology now for some time, those antibodies used to be called anti-Hu and anti-Yo and anti-Rai. Probably some of the oldest described antibodies. And if you still have the old paraneoplastic panels, it usually used to start with these and don't have any of the other ones. Anti-Hu usually happens with lung cancer, small cell, and also neuroendocrine tumor. It's an interesting antibody because it can be seen in sensory neuronopathy and peripheral disorders, but it also can present with brain changes and seizures, although seizures are rare. Anti-Rai, on the other side, comes with a lot of problems with the airway and the jaw abnormal tone. So it's very characteristic when it's seen. And the brainstem also has changes in the back of the brain, which is one of the rare causes of what we call rhombin encephalitis. And seizures are rare again, but it is associated with small cell lung cancer. Anti-Ma is a small cell lung cancer and also can be seen in germinal cell cancer like testicular cancer, can be an important cause of focal seizures, so very important to consider in people with refractory focal seizures. And we see the typical bitemporal hyperintensity on the MRI. And although seizures are rare, they could be very refractory to treat. CRMP5 is an antibody that is interested because it usually affects the spinal cord and it can cause abnormal balance. It can affect the back of the brain, like the predecessor that we spoke about. But interestingly, when I see a patient with ataxia or spinal cord features, and I see that they have unawareness seizure, I usually say we should probably consider CRMP5 in this case. Again, a good correlation with small cell lung cancer and thymoma. There are some antibodies that are now kind of considered to be very rare causes of seizures. What we've been seeing, like GFAP, meningoencephalitis, we have reported a case in the past about this. It's a very rare entity of fulminant type of encephalopathy, difficult to treat. IGLUON5 is a very interesting autoimmune antibody because it can present with a sleep disorder, usually a REM and a non-REM disorder, and sometimes can have nocturnal frontal lobe seizures. And I've seen a couple of cases where the patient actually, initial presentation was a REM disorder, and they found to have both nocturnal seizures and a sleep disorder in the IGLUON5. AK5 is a new antibody that has been described as a cause of limbic encephalitis. We still are kind of trying to gather some more information about it. I'm going to stop for a minute and just tell you a bit about the prognosis, but because most patients who have the first type of the antibodies, the cell surface, tend to have better outcome than the subcellular one, just because those ones are thought to be of cellular immune-mediated therapy, immune-mediated pathology, and these are usually more damaging. By and large, 15% will go on and have chronic epilepsy, unfortunately. And in certain disorders, we can use some biomarkers to predict the behavior, like an LGI1, the CSF titer can be helpful. And if there's an IgG4 subclass, that means they have a worse outcome. In NMDA encephalitis, if we see delta brush, the EEG pattern we talked about, it can be a worse outcome. And also they developed a score at the time of admission called the NEOS criteria that can predict the function at 1 year. So we do have a few tools, yet there are not that many to predict the outcome in these cases. Just finally, I have to say that there are certain diseases that are not autoimmune per se, but inflammatory, like MS and NMO, that can cause seizures. But most interestingly, or most recently, an entity called MOGAD, which is related to the antibody against myelin oligodendrocyte glycoprotein, can have seizures in about 14% because it does have a cortical inflammatory component to it. And this is an entity that is being discovered. It's one of the newest demyelinating diseases and it's attracting a lot of attention. Neurosarcoid is a rare inflammatory disorder of the brain, and because of the heavy meningeal involvement, you can see seizure up to 15% of the time, and similarly in cases of vasculitis. We spoke about MOGAD a little bit. In pediatrics, MOGAD presents in a condition called ADEM, which is acute disseminated encephalomyelitis, acute demyelinating encephalomyelitis. And that is a case that is well known to the pediatric neurology group. However, in adults, it can present like MS with a spinal cord involvement and optic neuritis. As I said, up to 14% of these cases can have seizures with them. There is now a good way to diagnose those with the new criteria described in 2023. And currently we have no approved therapy, but there is some suggestion that some of the treatments we use at first line, such as corticosteroids and IVIG, has good response to it. Rasmussen, as we said, Rasmussen encephalitis was described back in the 50s, very rare entity. It's still not clear to me if this is truly an encephalitis or the immune system is just being activated because there is another cause for the progressive atrophy. But the hallmark of this disease is progressive atrophy of one half of the brain that tend to be relentless and unremitting with associated refractory seizures. Unfortunately, there is no good therapy for this apart from surgery, where they do hemisterectomy or hemispherectomy to try to eliminate the source of the seizure disorder. So it's one of those, I call them orphan zebras that in spite of being described now for many, many years, we still don't have a good grasp over it. There are some certain studies that suggest some insult around the time of in the prenatal period, around the time of pregnancy or delivery, that might be associated. And interestingly, there was a case series that suggested twin deliveries, like, those patients would have a twin sibling, which might suggest some of the genetic component of these disorders. There has been one antibody described in this disorder, which is the mGlu3, but truly whether or not it's the etiology or a bystander is not clear to us. Now, what do we do when we see a case of autoimmune epilepsy or even autoimmune encephalitis? We start with the first line of therapy, which is usually IV steroids, and I usually do this for a period of time and try to see if it works. We usually give it a few days. There's a different practice. There's no hard guidelines to say when you need to switch from this to the second line, which is usually in our practice is either IVIG, intravenous immunoglobulin, or plasma exchange. And those surface antibodies tend to be more amenable. However, as we say, in cases when we have subcellular antibodies and we thought to be facing cellular immunity, then we consider different entities such as cyclophosphamide, and in some cases, I've put you in the last triangle there, some of the advanced monoclonal therapies, some of which are just being considered recently in cases of NORS and fires. Now, these are usually considered to be last resort. That's correct. However, in certain patients, when we have high suspicion that they're not going to do well, and the entity is very fulminant, we might jump quickly to consider those before we have to exhaust the other first and second line. Now, some of the unanswered questions that I myself struggle with is when to switch between those first and second lines, as we say, how long to treat with, how often should we repeat cancer screening, and what's the best choice we have to go for with all the third line that we have put together, and that is, open for debate, which ones are considered to be favorable in terms of side effects and efficacy and cost. And finally, about 5 to 10% of patients fail to respond to all of the above. So what do we do with these? So how do we think about anti-epileptic medication? So theoretically, some of those agents, first of all, it's thought that if there's an immune cause for the seizure, it's less likely that the seizure medication will do much, but treating the immune response will be the nidus. But let's say we're treating somebody with NMDA encephalitis, then it's better to avoid ketamine because ketamine does work on the NMDA as a blockade. The same thing with the Piramab panel, because that's an AMPA blocker. So if you have somebody with an AMPA antibody related encephalitis, then I don't think it's a good idea to use that anti-seizure medications. Benzodiazepines and barbiturates kind of promote GABA function, so they can be considered in GABA B antibody cases. This is actually the other side of the argument, to use an agonist. And Depakote, for example, sodium valproate can potentiate an immunosuppressant risk of the bone marrow suppression because of the metabolic CYP system. So it's an important consideration when somebody is on chronic immunosuppression if sodium valproate is to be considered. So some of the future thoughts that we spoke about earlier, that immunotherapy in a drug-resistant mesial temporal lobe epilepsy with different types of hippocampal sclerosis. This is a paper that was published in 2017 to talk about the immune system activation in drug-resistant epilepsy. And it's basically argues to that concept that seizures, when refractory themselves, can ignite the immune system and can cause chronic inflammation. So there is a proposal, or there's a thinking process that even in seizure patients who are chronic and refractory, without the fact that they have an underlying autoimmune antibody or a cause, would it be helpful to negotiate or to block the immune system and the immune response? Because even though it's not the etiology, it becomes a secondary mechanism that can drive more inflammation and maybe worsening of the overall condition. It's some of the kind of future debates that I think we'll see upcoming as we know more about these entities. These are kind of some of the references that I've put for my study. They will be available for you. I'll stop here. I hope that I haven't exceeded my welcome that much. It seems that we're still good. We have a few minutes for questions. So Tabitha, back to you.
Yes, we do have some good questions. We have had someone who has raised their hand a few times. I recognize the name as someone from Sudan. And if you can put your question in the question box that says Q&A, you've raised your hand a few times, so I hope we can get to your question. The first question, are you aware of any correlation between positive HLA-B27 gene and GAD65 autoimmune encephalitis cerebellar ataxia diagnosis?
I am not aware of that. I thought HLA-B27 was, if I remember correctly, mostly an ankylosing spondylitis, and it can be seen in other rheumatological conditions. However, as I said, there's a GAD65. We have to be a little bit careful about the definition. The level of the antibody is very important to make it a label for the neurological disease. A low titer GAD65 can be seen even in normal humans, in people with diabetes, but they usually are considered to be non-pathological for the nervous system. So usually high titers, or if the antibody itself is present in the CSF, they're only, we call this a GAD65 mediated neurological syndrome. I see a large number of misdiagnoses of encephalitis because the patient was found to have a low titer of GAD65. And this, unfortunately, is a very common mistake that we see in general practice.
And that is such an important thing to bring up. Do you want to take your slide down just so we can have a bigger picture of you
Sure.
as we're as we're doing our
Let me stop
questions and
sharing.
answers?
There we
There you
go.
go. Um, we are getting a lot of personal questions. We cannot answer specific questions to a case. However, several of these, and you just answered one on GAD65, which is extremely important. They're all around people who have just entered the AE community because their person has received a diagnosis, they're just out of the hospital, and the general question to what they're asking is, what do we expect? My person has memory problems. My person is not the person before the disease. Is there a general way to help people understand the journey before them?
Yes, unfortunately, in the world of autoimmune encephalitis, although miracles are welcome, they usually don't happen. Meaning that in the true autoimmune encephalitis, the course is unfortunately protracted. It's a long journey. And we have to understand this from the beginning. And this is probably one of the very first statements that I say when I see a patient with that issue. And I say, if you are a person who will give up the first herb, that this disease is not for you. Unfortunately, we don't pick diseases, they pick us. So we have to learn resilience. And we have to be very much aware that the brain is a very sensitive machine because it controls every certain bodily function. So it can talk to us, meaning that we might see a lot of symptoms that remain. Some of them are ill-explained. So some of symptoms, the doctor will even have difficult time correlate them with the encephalitis itself. And we sometimes see a sequelae that is not related to the disease itself, let's say depression, anxiety, chronic pain, whether or not these are related to the disease itself or a sequelae just from the person being ill and going through a difficult experiment and sort of experience in their life is not very clear. But the moral of the story is that the patient has to have an understanding. So their family is that the healing will be stepwise, rehabilitation, rehabilitation, rehabilitation. I say this over and over again because there is a very high value. Rehabilitation is probably even more valuable than the therapies we use themselves because the brain is like a muscle. The brain has something called neuroplasticity. If it is used and it is tested, it will develop a neural network. Let's take stroke as an example. Stroke has no autoimmune cause, well, at least from what we know to it, but the patient responds well, although that patient has a damaged nerve tissue from the stroke that will not come back, but you see the function coming back, meaning that the brain has a high potential for rehabilitation. And I think that should be in the very core of the treatment of autoimmune encephalitis.
We like to say it's a marathon and not a sprint, and we call it a journey deliberately because it is a long journey. Improvement is slow. When we were talking backstage, I told you that I came down with autoimmune encephalitis in 2013. So although I live with lasting deficits, I have a very full life. I enjoy my life. It may take me 3 or 4 times to get something accomplished as it would have prior to my illness. Um, but I think we hold fast and resilience is key. And focusing on neuroplasticity is also key. Another question was, how do you and this is from a family member. Can you see damage on the MRI versus brain
Yes,
injury?
Yes, we can. Now, damage is a little bit of a generalized term, but we can see an equivalent of damage, which have different terms like brain atrophy, what they call encephalomalacia, which means an old tissue that is damaged in the brain. There are some advanced MRI techniques that are not the conventional MRI that can give a little bit more understanding, like what they call DTI, spectroscopy. Uh, so yes is the answer. We can see it, but sometimes you can't appreciate the damage itself, but you see the equivalent of damage. Let's say in temporal lobe, when we see atrophy, the brain's getting smaller. That means that this area has suffered some damage, and that's why it's not as big as the counterpart.
There's another question, general. How do you diagnose? What tests do you do to diagnose autoimmune encephalitis? Someone's going through that process.
Right. So to be very honest, I don't think there's one test, and I
Right.
always say 1 + 1 = 2 because it's a very simple question, so it has a very simple answer. In medicine, usually, especially in those diseases which there is a high rate of misdiagnosis, the presentation can be very wide in terms of the phenotype. There is no one test. There is no equivalence to a good clinical evaluation. There is no equivalence to hearing the story. There is no equivalent to putting all the tests together and looking at them in totalis. Having one abnormal blood test sometimes doesn't mean much. Having one abnormal
Right.
MRI doesn't mean much. Having somebody who would present with some symptoms that are non-specific and some non-specific antibody that does not relate to those conditions, the description we have just said, because each of those antibodies have a certain entity and an antibody can produce a certain picture. So sometimes I see a patient who come to me with a certain complaint, but the antibody that they found in their blood is probably not correlated. So labs can be mistaken. And I usually say, don't treat the labs or the test, treat the patient, because I think we're all in the business of treating patients. And it will be most of the harm and the misdiagnosis I've seen being done because the response we generate is based on the test itself, not because that we have assessed the condition well.
Right. There's a doctor in Sudan who wants to thank you very much for the information today.
Thank you for joining us.
Can symptoms be severe, then mild, then severe without medications?
It's a very good question. The answer is possibly if we're seeing recurrent episodic incidents. However, as I say, the brain is a sensitive machine. So even if we take people without encephalitis, let's give an example as dementia. You see patients with dementia improving and worsening day by day, minute by minute, hour by hour. Why? Because the brain is affected by the rest of the body. So sometimes general illness, sleep deprivation, diet, stress, anxiety will affect the brain function. The brain is a very eloquent machine. So whether or not that worsening is it due to the immune response or just because the patient has some brain damage and their threshold to tolerate injury is less than others, is yet to be determined.
And here's a very difficult question. I'm going to make it the last one due to time, and I hate to throw this at you, but someone is asking, when can a patient stop treatment? When do you know that?
It's a great question. And
I
as you said,
know.
it's one of the most difficult because it's an art. There is no cookbook for this. But I tell you
Yes.
this, you remember when we were going through those syndromes, some of them have high recurrence rates and some of them have lower recurrence rates. The advocacy has been that when the patient is past the acute phase, which means that they're out of the hospital, the episode has passed, we continue to monitor them. And some patients, some of my colleagues don't even treat past that first episode, thinking that that's it, it's done. And we don't need to keep the patient on them. I've seen 6 months, I've seen 12 months, I've seen 2 years. I've seen patients who do very well on a very low risk therapy and they don't want to stop it. And there is a process about how to get them off or to wean them off. But by and large, the golden rule here is that if we see a disease, a syndrome with high recurrence rates, we have to do protracted immunotherapy. I would say 1 to 2 years at least, with very, very slow weaning off process. If we see an entity where there's less likely to have recurrence and it's usually monophasic, I usually don't treat past the first few months.
And we're going to leave that there. We have so many questions coming in. We could be here for hours, and and that's just because it's a fascinating topic.
Yes, it
You
is.
know, I want to thank you for the time you've given us today. It's been absolutely outstanding. And for those of you who didn't get your questions answered, review the recording because a lot of your questions are embedded in his presentation. And so with that, we'll say goodbye. Thank you so much for joining us today.
Thank you for having me. Have a good day now.
All right. Bye-bye.